Thank you for choosing Axxess On Demand. We're the fastest growing home health technology company, helping improve care for more than 1.5 million patients and trusted by more than 7,000 healthcare organizations to grow their business. Axxess is a firm believer in continuing training, and we create content so you can learn and grow anywhere, anytime. Let's get started.
Hello again, friends, and welcome to Axxess's Home Health Conditions of Participation webinar series. I'm Jennifer Gibson, your trainer, and I am an OASIS and coding certified registered nurse. And today we're going to deep dive into section 484.60 of the updated regulations and standards, which covers care planning, coordination of care, and quality of care. A chance to read any Medicare or CMS home health reports or publications in the last couple years, you already know that quality care, patient satisfaction, and population health, as well as the cost of providing services, are a focus of the care delivery in our industry. This section, 484.60's standards, align regulation with the triple aim focus. So let's dive in and explore the new regulation. Our objectives today are to learn the updated regulations for care planning, coordination of services, and quality, to become knowledgeable in changes regarding the information that must be provided to the patients that we serve, to identify ways the agency can increase transparency and coordination of care with the physician and the healthcare team as a whole, and to understand the agency's responsibility in ensuring these standards. Going back to the Federal Register that first proposed these conditions of participation changes in 2014 and continuing through the final Federal Register that finalized them, we see certain principles integrated through the updated standards. Among these principles are continuity and integration of care processes across all the aspects of home health services, which are based on a patient-centered assessment, care planning, service delivery, and QAPI system. And we see the use of patient-centered interdisciplinary approach that recognizes the contributions of various skilled professionals and their interactions with each other to meet the patient's needs. Surveys in the near future will focus on patient-centered interdisciplinary care and outcomes rather than focusing on the services and processes that have to be in place. Section 484.60 is found in Subpart B of the updated Home Health Conditions of Participation. The majority of this section is new or revised in some way. This section's changes are directed at improving patient-centered outcomes of care and engaging the patient, the family, and the physician in the care planning and care delivery process. Research cited by CMS shows that this approach will help the patient become more engaged and hopefully compliant, which will increase the outcomes and the patient's satisfaction. I've broken the preamble or the overview at 484.60 into several parts for the sake of teaching. First, you see here on this slide that patients are accepted for the treatment on the reasonable expectation that an agency can meet the patient's medical, nursing, rehabilitative, and social needs in his or her place of residence. What that means is that when we accept and admit this patient, we believe we have the staff and the disciplines to take care of the medical issues, the nursing and therapy needs properly, and that we have the social worker and or psychiatric staff to meet the patient's social needs. Now, social needs include things such as relationships in the immediate family, financial status, their homemaker and household needs, vocational rehabilitation needs, family social problems, transportation needs, and recreational needs. And certainly we know, if you've been in home health very long, you'll know this anyway, that oftentimes there are family members and problems and frictions amongst families, and patients have social interaction needs. Maybe they're isolated, they don't have someone to take care of their household needs, they can't do it themselves, and so on. So if a patient has social needs that go beyond the capabilities of the agency and or they might interfere with the safe delivery of care by that agency, the home health agency would not be accepted to accept that patient for care. So really, you need to think about your referral intake person working with the clinical manager and assessing clinicians so that you can determine or assess if that patient is appropriate for your agency. or if they're even appropriate for home health care in general. All of that are things that you can assess from the very beginning, from referral, but certainly by the time you do the initial and the comprehensive assessment. The second part of the preamble says, each patient must receive an individualized written plan of care, including any revisions or additions. Note, we aren't seeing the word 485. Industry standard verbiage now states plan of care, as the 485 is no longer a CMS endorsed or mandated form. So I want you to get your head wrapped around that. The 485 is what we're familiar with. It came to be and actually got its name because it came about in April of 1985. But some time ago, and especially with implementation of the face-to-face encounter, that 485 that we are accustomed to is no longer a CMS endorsed form. But we do have information about what is a plan of care and what is contained in that plan of care and so on that we have to follow. The second thing to know about this is that all patient care, regardless of the level of clinical skill involved, should be delivered in accordance with a plan of care. Even if you're doing non-skilled medical care, that needs to be under a plan of care. Not using a plan of care creates opportunities for uncoordinated care, duplication of services, and missing services. In my years of experience, it was not at all unusual for me to be in agencies where maybe there was an issue with getting the original OASIS or Recert OASIS turned in timely and the subsequent plan of care being turned in timely, or there were holdups in the QA process for that. And so you would have nurses following this evaluating RN who didn't have a plan of care to reference. And that simply won't fly, because in those circumstances, often what you see is a nurse just going out and teaching or performing what they think they should be doing and not following that plan of care. That's the equivalent of not following doctor's orders, because the plan of care is literally your physician orders written out on a plan of care. So we're going to talk even more about that plan of care in a little while, but just know that you have to get that plan of care created and work with that so that you don't have uncoordinated care or duplication of services or even missing services. The next two statements of the preamble state that the plan of care has to be individualized, specific, based on the comprehensive assessment, and contain measurable outcomes that the agency anticipates will occur from the care provided by the agency. This plan of care must also specify the patient and caregiver education and training. Now, one of the tips I give clinical field staff regarding developing a patient-specific plan of care is to think about what makes this patient different. For example, you're admitting a patient who had a CHF exacerbation. There are hundreds of patients who are discharged home after a CHF exacerbation who don't require home health intervention. So when you're out there assessing that patient, think about what are the specifics that make this patient different. Maybe they can't afford their medications, or maybe they can't prepare healthy foods. Or maybe they're in a food desert where they can't get their hands on fresh fruits and vegetables, so they rely on prepackaged foods or quick fix foods. Maybe they have a poor understanding of the signs and symptoms of the disease process that they need to report quickly before they turn into an exacerbation. Maybe they don't have a caregiver to help them out. They don't have transportation to the physician's office for follow-up and so on. So what is it that makes this particular patient different? And you're going to want to include that in your patient-specific interventions and goals in your plan of care. At 484.60A, we deep dive into the plan of care requirements. Number 1 that you see here is a new standard that states each patient must receive the home health services that are written in an individualized plan of care that identifies patient-specific, measurable outcomes and goals. This is where your comprehensive assessment skills come into play. The comprehensive assessment of a patient is the head-to-toe assessment plus the assessment of the patient's medical, nursing, rehabilitative, social, and discharge planning needs, as well as that patient's strengths, goals, the patient's care preferences, which, by the way, all of that is new in the conditions of participation, especially documenting that patient's strengths and goals and care preferences. You also have to assess the medication regimen review, and reconciliation with a discharge med profile, for example. You have to assess the availability of the caregiver if they have any, the patient support systems, and the representatives if they have any. And then on top of that, you have the OASIS items also. I say that as just a reminder that the OASIS items and a head-to-toe assessment is not everything. You have to consider all of those items that we just said. In order for a clinician to gather this information, it takes a skill set that includes trust building with that patient, relationship building, strong assessment skills, and time. And I can't emphasize that last part enough. I don't know how many times I've seen administrators want to load an admitting clinician up and give them, 3-4 assessments or admissions a day, and expect that to be done thoroughly and timely. And considering all that has to go into this comprehensive assessment and making sure that it's patient-centered, I want you to really think about identifying those clinicians who have the abilities and then use them as your assessing clinicians. And you also want to keep in mind some kind of productivity scale that you can keep up with that factors in travel times and how much time they need to be in the home with the patient, and gathering information from the referral source, and coordinating with the interdisciplinary team, and coordinating with the physician about anything that needs to go on the plan of care that was not initially on the referral, orders, and so on. That takes a lot of time. Now, some agencies have only certain staff members perform their OASIS, and what I would recommend would be that you use those clinicians as preceptors for the other clinicians who maybe are not as strong in their assessment skills. Pair them up, because as you continue to grow, you're going to need a large group of clinicians who are proficient in a comprehensive assessment and plan of care building. And then you also want to do onboarding training and skills assessments. And as I said in my prior webinar, it was not at all uncommon in my experience, having worked in 3 different states in the Southeast, that I would go to an agency after being newly hired, and as soon as we got the tax forms filled out and whatever prerequisites done, the next step was not to read policies and processes or to be onboarded with a preceptor or something like that. Quite often it was literally, here you go, here's 2 admissions and 2 research, and I kept them in the same area. And what that administrator and agency may or may not know is whether or not I am filling out an OASIS correctly, or whether or not I have correct assessment skills, or whether or not I know how to adequately and properly reconcile a medication list with what's in the home. So really, you're doing yourself an in-service if you're not doing some onboarding assessment and training of this RN's skills and abilities. When you see after the underlined part that says each patient has to receive the home health services that are written in an individualized plan of care that identifies patient-specific measurable outcomes and goals, the next part says, and which is established, periodically reviewed, and signed by a doctor of medicine, osteopathy, or podiatry acting within the scope of his or her state license, certification, or registration. That second part really relates to the certification and requirements that have to be met in order for them to receive the Medicare home health benefit, and also speaks to the requirements for the Medicare patient or Medicaid patient to receive the home health benefit under their payer source. And then lastly, it says the physician is consulted to approve additions or modifications to the original plan. That needs to be well documented in the chart as well. So maybe the nurse goes out and the patient needs physical therapy, but that's not ordered on the plan of care. It shouldn't just magically appear on the plan of care. There should be documentation that thoroughly talks about what the findings were that led that clinician to believe PT is a good idea or is needed, and then that was coordinated and spoken to the physician, and that orders were received back. And all of that should be documented very well in the chart. Some keywords to consider when you're thinking about the plan of care that was documented in the COP regulation. Individualized, that means that it's tailored to suit that individual. So it custom fits that patient. Patient-specific means it's unique to a patient or unique to the patient's diagnosis or treatment. And measurable means it's large enough to be measured, it's noticeable, it's definite. Remember, your plan of care must be individualized or tailor-made, unique to that patient and his or her diagnosis or treatment. Don't include cookie-cutter statements such as, skilled nurse will instruct on disease process of CHF medications and signs and symptoms. Think again about what it is that's unique about this patient that causes him or her to need home health and what contributed to this recent hospital stay or recent change in treatment. Maybe they can't ambulate safely to weigh daily. Maybe they can't afford their medications. Maybe they're afraid of falling when that furosemide starts to work and they can't safely ambulate to the toilet, so they just don't take the furosemide, and what do you know? CHF exacerbation, right? And let those identified factors be your guide for building that individualized plan of care. Other things to consider when you're creating a plan of care. What does the assessment reveal? What should be done? How, when, and where should these planned interventions be carried out? What's the desired outcome? Will the delivery of planned interventions result in the desired goals? That's really what you need to be thinking about. Let's take our CHF example further. What should be done? We would want to coordinate with the physician to get a commode chair ordered for use until that patient demonstrates safe ambulation, for example. We would be instructing on the use of the commode chair to decrease falls. We would instruct on the action and side effects of furosemide that can contribute to issues such as frequency or decreased potassium, which might lead to weakness. And then we want to teach the patient to identify those signs and symptoms or side effects and know when to call and report and who to report those problems to. And then, of course, we'd want to educate and coordinate with the family or the caregiver or the representative, if they had one, on the importance of assisting the patient with safely weighing and recording the weights, and also with encouraging them to use the commode chair, encouraging them or having them encourage the patient to take their medications properly, and so on. And all of that would show patient-specific interventions and goals, and also coordination of care with all these family members and caregivers and such. And then your desired outcome, that would become your goal. For example, patient's weight will remain stable between 145 and 150 pounds, and patient will not have an exacerbation within the next 6 weeks, right? And then will delivering this care result in that outcome? Certainly, if there's problems and you've addressed and taught on them, it certainly should result in the desired outcome, which is no more CHF exacerbation, patients weighing properly, they're transferring on the bedside commode without any problem, and then as the PT works with them, perhaps they're now able to ambulate to the bathroom safely, and all of that should be painted in that clinical picture in the chart. At 484.60a, we see the plan of care, and again, I've underlined for emphasis new items and new thoughts in the home health conditions of participation here that have been updated. For number 2, you see the individualized plan of care must include the following: all pertinent diagnoses, the patient's mental, psychosocial, and cognitive status, and the types of services, supplies, and equipment required. Let's think a minute about all pertinent diagnoses. First of all, in order to properly add diagnoses on an OASIS, according to the OASIS C2 guidance manual, it's stated in that manual that in order to fill out the diagnoses items properly, that we have to follow official guidance for reporting ICD-10-CM diagnoses. And in the official ICD-10-CM diagnosis coding standards, it tells us that the primary diagnosis on an OASIS should be the primary reason for home care. Your secondary diagnoses should be all the other reasons the patient is receiving home care, and they should be sequenced according to their acuity level. Doesn't say according to their payment generation, but according to the acuity level of those other diagnoses. And then lastly, where some people get a little bit foggy and you hear urban legends about you don't need to put more than 6 or more than 9, the official guidance says you are also to add any diagnoses that may have some bearing on this patient's ability to rehabilitate well. So, for example, the patient has diabetes and they have a wound, and you're in there for wound care. The assessing clinician notes that the patient has diabetes, but assesses the patient's abilities, and the patient perfectly well knows how and demonstrates how to check their blood glucose on the monitor. They can tell you how to QA check that monitor, make sure that it's reading within the correct ranges. They know how to document their glucose levels. You review that glucometer and see that their glucose has been within a normal limit for that patient. They're keeping real good control. The patient voices what all of their diabetic meds are for. They can give their own insulin, all of that stuff. Sometimes you will see agencies who will say, we don't need to add that then because it's not really while we're in the home. But again, according to those regulations in the official coding set, if it's going to, and also in your OASIS guidance manual, if it has the potential to affect your plan of care and the patient's rehabilitation, you need to add it. And certainly we know that diabetes does have a potential to slow wound healing. So we would add diabetes anyway, although it might be at the bottom of the list. And we certainly shouldn't put it in the top 6 payers or the top 6 diagnoses, because those are your payer code slots. We shouldn't add it there in this case. If there are 8 diagnoses, for example, we shouldn't pop it up in number 6 to get payment because we're not going to be doing anything, and that's not why the patient is on home health. It just has the potential to affect our plan of care. It's a little sidebar on that, but hopefully you understand what we're getting at. And certainly if you need more information on that, you can refer back to our training library of on-demand videos, and there's actually an ICD-10-CM coding webinar series where we cover all of that. You see at 484.60A2, number 2, the patient's mental, psychosocial, and cognitive status. Again, this is talking about that family's relationships, their financial status, the homemaker household needs, vocational rehabilitation needs, family social problems, transportation needs, recreational needs, and so on. Can the patient process the information given as well? What is their education level? What is their literacy level? Are they depressed? Do they have dementia? Do they have anxiety? Are they overwhelmed? And that kind of thing. Certainly we know that that can be a problem if they are so depressed and anxious that can impact their plan of care. And so we need to know whether or not we can handle that. What is it that the nurse or the clinician observes? What does that patient's health history reveal? What does the medical record review show? Analysis of labs and the diagnostics will also give you information. What does that tell you? Again, if we have that CHF example, you think about with CHF patients having an altered oxygen supply and fluid overload, that in itself can lead to confusion, somnolence, restlessness, irritability, hypoxia, and you're going to want to use that information to show the medical necessity and build that care plan and your interventions around that patient-specific finding that goes with CHF. Remember, your staff has to be aware of the social and economic circumstances in which people are born and how they grow up and they live and they work and age, as well as issues or factors in place for their overall health care. You may have patients that were born in a poor socioeconomic level, and so, if something breaks at their house, they don't throw it out and go buy another one, even if they have the finances. They may try and fix it themselves, and then they don't get around to it, and so on. So you have to really kind of know that person. It's not just a drive-by and in and out little assessment and on you go. You really have to know what's going on with your patient. And that helps to identify the resources that that patient may need in order to result in your best outcomes. Also, sometimes, and I've had to do this in my career, you may not understand the diagnosis itself. Certainly, we don't in home care encounter every diagnosis on a daily basis. And if you've been in home care for a long time or in nursing, for example, for a long time anyway, there may be some diagnoses that you need to brush up on a little bit. So sometimes you may even have to go back and do a little studying about that patient's diagnosis to understand what it is that's going on and what to expect. And then even more importantly, does that patient or family or caregiver or representative, do they understand the patient's diagnosis? All of that has to be factored in when you're doing care planning. Here on this slide, we talk about what the pertinent diagnoses are. Just as a reminder, I've listed them here. Your OASIS C2 guidance manual says all diagnoses for which the patient's receiving home health care, and then your ICD-10-CM official guidance for coding and reporting also tells you to sequence those that might impact the patient's plan of care. Going on, some more things that must be in the plan of care include the frequency and duration of visits to be made, the patient's prognosis, rehabilitation potential, functional limitations, and activities permitted. None of that is new, by the way. Just something to talk about as reminders on your frequency and duration of visits to be made. Remember, 0 week 1 or 0 week 2 is not a recognized frequency. You may have certain systems that require you to put that in order to count out your frequencies and make sure that you're following those. But again, remember, if you're admitting a patient on a Friday and you're not going to go back until the next Tuesday and they're really acute, does that make sense? Especially if you're doing a recert, for example. So again, just recognize that 0 week whatever is not a recognized frequency. If you have to use it for your software, put a note in the chart that you realize it's not a Medicare endorsed frequency. However, the software must have that in order to generate the counts for your frequency and duration. Duration, by the way, is the amount of time for a given frequency. Also refers to visit links and or intervention links for therapy services. And then CMS expects your plan of care to contain patient-specific frequencies and durations based on the needs as assessed in the patient assessment. So 1 week 9 does not fit the need for all patients, especially those who are acutely ill. You want to see that being patient-specific. Some patients require a more intense level of services based on their needs, and not all agencies have the staff, like a social worker, to meet all that patient's needs. And again, CMS said in their comments in the final rule, if the patient's needs exceed the abilities of the agency, that patient should not be accepted for care. Make sure your therapy services include the specific procedures and modalities to be used and the amount, frequency, and duration of those modalities. The prognosis is your clinician's best estimation. Your rehab potential or the expected outcome of maintenance therapy can be to preserve and maintain the patient's current condition or to prevent or slow further deterioration. And that's thrown in there for those who might have maintenance therapy ordered on recerts rather than regular therapy. Just remember, your rehab potential may not be good, fair, or poor. It may be something that you see here in this first bullet. Also, the agency must specify the purpose of the skilled service required. That's also in the comments on the final rule. And that would be just documented throughout your medical records on why this skilled service is required. And remember how we were talking about that CHF patient and what specifically made them different? That's going to really do that for you. If you document all that well, that's going to specify the purpose of the skilled service required that's individualized for that patient. And remember that plan of care must have measurable goals. Then you have your functional limitations and activities permitted. We must also document nutritional requirements, all the medications and treatments that this patient has ordered, safety measures to protect against injury, and a description of the patient's risk for emergency department visits and rehospitalization, and all necessary interventions to address the underlying risk factors. Your risk for ER visits and hospital readmission should be done for all patients admitted to your home health agency. Now, your policies are going to have to define a system to identify the risk for ER use or rehospitalization. You might look at some data that you're already able to obtain through your 5-star ratings or your Casper reports and so on, things such as the number of ER visits the patients had in the last 6 months, for example, or the number of hospital admissions in the last 6 months, or maybe you want to do 3 months instead, the number of medications the patient takes, whether or not they have certain high-risk medications according to a Beers list or so on. You may look at medication reconciliation discrepancies and safety issues, but it's up to you and your agency to define what that risk factor is and develop a checklist or whatever you prefer to use, but those are some factors that I can think of. And then perhaps you take the total number of factors, and depending on how many factors they have, you would rank this patient as low, medium, or high. But by the way, low, medium, and high risk was removed from the final rule, from the proposed rule for COPs, as CMS said there were no standards to use across the board. So your agency policy really is going to have to identify its own risk assessment factors and then monitor the accuracy of whatever tool you devise through your QAPI program. You also want to include all the appropriate interventions that are necessary to mitigate those identified risk factors. So, for example, if one of the risk factors is that they have 4 high-risk medications according to the Beers list, that you're going to want to teach on those 4 medications before other interventions or whatever. You're going to want to teach on those and monitor and so on. Also, your nutritional requirements, make sure that you have policies and processes on what is appropriate to list as a nutritional requirement or not. Depending on your accreditation agency, that might be different than just licensed and certified. Make sure you list all the medications and treatments, including over-the-counter, herbals, peg tube, inhaled, topical, those medications applied to the eye or the ear or the skin or sub-Q or sublingual, all of those, and all of the treatments the patient receives, your safety measures to protect against injury, and then if you really want to get into some good information about best practices regarding hospital readmission, I would recommend or have you go to homehealthquality.org. That's homehealthquality.org, all lowercase, and that's the Home Health Quality Improvement Association. They have some really good tools that have to do with best practices. Again, your individualized plan of care must include patient and caregiver education and training to facilitate timely discharge, patient-specific interventions and education, measurable outcomes and goals identified by the agency and the patient, and information related to any advanced directives. And really, what I want you to think about with the education and training to facilitate discharge of this patient, an example that was brought up in the final rule for the home health COPs gave an example about diabetics with insulin. So when we're talking about patient and caregiver education and training to facilitate timely discharge, CMS expects training to help those diabetics self-manage their diabetes. And if they're unable to learn to self-manage, including how to self-administer insulin or medications, then that agency is expected to provide the teaching and training to a caregiver or a family member. They want you to get organizations involved that teach innovative solutions and techniques, perhaps, and even collaborate with all of those different types of providers and caregivers. Now, it's perfectly acceptable if you're doing that and there's no willing or able caregiver, they don't get it, they can't get it, they refuse to. All of that just needs to be documented on an ongoing basis, however. And that's not just with your diabetic patients who require insulin, but really any other type of issue that's going on. But really, when you think about facilitating timely discharge, remember the reason for Medicare and Medicaid home health is to help the patient and the caregiver and the family adjust to whatever this acute illness is and help them learn how to manage that. And then we are to come out soon thereafter. Now, the exceptions to that, of course, are maintenance therapy, when that helps to keep the patient from declining, and there's some specific guidelines as to what that means in Chapter 7 of the Home Health Manual. And again, by the way, if you need to find that manual, just Google Publication 100-2, Chapter 7, Home Health Guidance Manual, and you'll be able to pull that up from CMS's website. Again, just remember we're talking about patient-specific interventions and education, measurable outcomes, and information regarding advanced directives. And then last, you can add any additional items to the care plan that the agency or the physician may choose to include. All right, the next standard at 484.60 has to do with patient care orders, and it simply says, all patient care orders, including verbal orders, must be recorded in the plan of care. That's pretty self-explanatory. At 484.60B, number 1, conformance with physician orders, we see that drugs, services, and treatments are administered only as ordered by a physician. And I would make sure that my home health agency policies state that all clinical services are implemented or administered by a physician's order, and then what kind of orders you accept. Do you accept faxed orders? Do you accept verbal orders? And if so, by whom? Do you take orders from discharge planners or nurse practitioners or PAs and so on? And then do you ensure that if you're taking orders from a nurse practitioner or PA, that they are authenticated by the certifying physician and so on? Do you take written orders, and how do you authenticate them and so on? Your notes have to document, by the way, the history and physical exam pertinent to that day's visit, including the response to changes in behavior to previously administered skill services, the skill services applied on that current visit, and the patient or caregiver's immediate response to the skill services provided, and then a plan for the next visit based on the rationale of prior results. Why do we say that? Because in the prior slide, when it talks about drugs, services, and treatments being administered only as ordered by a physician, your documentation needs to address all of those orders and how you applied them and paint that picture about whether or not they help the patient. And if you find problems that need to be addressed, you're coordinating that care and documenting all of that. So your notes have to document that. Also, your maintenance therapy notes have to document detailed rationale that explains the need for the skilled service in light of the patient's overall medical condition and experiences, the complexity of the services to be performed, and any other pertinent characteristics of that beneficiary or the beneficiary's home. At 484.60b, Number 2, we see that influenza and pneumococcal vaccines may be administered per agency policy developed in consultation with a physician and after an assessment of patient to determine for contraindications has been made. So basically, if you and the physician who's on your PAC committee, or if you have a physician serving in a medical director role, which is not required anymore, by the way, for home health, you can actually write policies about flu and pneumonia vaccines and administer those based on that policy after you have an assessment of that patient. So you would want to have some kind of form laying out what you are assessing the patient for. And by the way, you want to consult that CDC website yearly for your contraindications and information on who should receive the flu and pneumonia vaccines and your shingles vaccines if you're in a VBP state, because the CDC regulations may change from year to year as far as who qualifies to receive those vaccines and whether or not they have an allergic reaction versus anaphylactic reaction, for example, and you're going to want your policy to match the CDC's guidance, okay? We see at 484.60b3, verbal orders must be accepted only by personnel authorized to do so by applicable state laws and regulations and by the agency's internal policies. That simply means that if your state law does not allow a receptionist who is not licensed to pick up the phone and take verbal orders from a physician's office, that they don't do that. And that's a very blatant example. I've seen that happen from time to time. There's too many possibilities for error, not to mention that state law does not allow that. So make sure your verbal orders are accepted only by personnel who are authorized to do so by their state professional practice acts and by your agency policies. At 48460B4, we see that when services are provided on the basis of a physician's verbal orders, a nurse acting in accordance with state licensure requirements or other qualified practitioner responsible for furnishing or supervising the ordered services in accordance with state law and the agency's policies must document those orders in the patient's clinical records. And here's the new part. They must sign, date, and time the orders. Now, we're accustomed to timing orders in all other practice settings. We now will be timing them in home health as well. And by timing the orders, we mean the time that the order was taken. Verbal orders must be authenticated and dated by the physician in accordance with applicable state laws and regulations, as well as the agency's internal policies. So at the time of implementation for the new COPs, which at the time of recording this webinar series, there is a proposal to delay those implementation of COPs by 6 months. And if that goes through, then that means that we will start timing the orders on January 13th, 2018. You may want to go ahead and start doing it now if your policies will allow that, but certainly no later than the implementation of the new COPs, be that July 13th, 2017, or if delayed, January 13th, 2018, we will have to record, sign, date, and time our physician orders. At 48460C, we see review and revision of the plan of care, and it says the individualized plan of care must be reviewed and revised by the physician who is responsible for the home health plan of care and the agency as frequently as the patient's condition or needs require, but no less frequently than once every 60 days, beginning with the start of care date. The agency must promptly alert the relevant physicians to any changes in the patient's condition or needs that suggest that outcomes are not being achieved and or that the plan of care should be altered. Now, it doesn't just say to alert the physician who's looking over and overseeing the plan of care, but it says alert the relevant physicians, plural. So there may be some coordination of care that has to go on amongst several physicians if you have a patient who has a lot of comorbid conditions. And CMS is just telling us that we have to alert all of the relevant physicians to any changes in the condition that might suggest that the outcomes are not being achieved or that the plan of care needs to be altered. At 484.60C2, it says a revised plan of care must reflect current information from the patient's updated comprehensive assessment and contain information concerning the patient's progress toward the measurable outcomes and goals identified by the agency and the patient in the plan of care. Now, some of this, as it pertains to the review and revision of the plan of care, we will have to await interpretive guidance to see exactly what they mean when they come out and survey us. But as I read 48460C2, really what I'm seeing is if we have to revise the plan of care, say after a hospitalization or a significant change in condition, or at research, that plan of care has to really reflect the current information from that comprehensive assessment, but it also needs to have information about the progress toward the goals and outcomes that we'd already identified, and then if and when we adjusted them, why did we do that? It really needs to paint that picture again of what's going on with the patient. The revisions must be communicated as follows. Any revision to the plan of care due to a change in patient health status must be communicated to the patient, the representative if they have one, the caregiver, and all physicians issuing orders for the home health agency plan of care. So if you have a statement on your home health agency plan of care for this patient that says agency may accept orders from Dr. Smith, podiatrist, Dr. Jones, pulmonologist, Dr. Phipps, cardiologist, and so on, when you have a revision to that plan of care because the patient has a change in health status, you have to communicate all those changes to the patient, the representative, the caregiver, and all of those doctors that are issuing orders for this patient during this episode. And again, we're talking about this focus on the coordination of care and interdisciplinary care team and best practices, and communicating this care throughout that team is certainly a best practice. Is it a pain in the behind sometimes? Absolutely. That's why it's important to have good software that will take some of that repetitive task away so that, for example, you can write one communication note and email that to all of your interdisciplinary team as well as send that out to multiple physicians at the same time. But remember, just sending a piece of paper or an email is not enough. There needs to be some two-way communication. Definitely, I would document somewhere that I made sure that they received the information, or maybe I called and followed up with Nurse Jackie at Dr. Shepard's office to ensure that he received the communication note and so on. And I know that's a lot of work, but that's what it takes to make sure that these patients get quality care. And again, we'll wait on the interpretive guidance to be published as far as exactly how your surveyor is going to assess whether or not this happens. Any revisions related to plans for the patient's discharge must be communicated to the patient, the representative, the caregiver, all physicians issuing orders for the agency's plan of care, and the patient's primary care practitioner or other healthcare professional who's going to be responsible for providing care and services to the patient after discharge from the agency, if any. So we're going a step forward. Let's say that we planned to discharge this patient in 60 days. And by day 40, we see that, wow, they've met all their goals. They're doing really well. They no longer meet the criteria for receiving home health. So we're going to discharge them early. We have to show documentation, and we don't know exactly what that's going to look like until interpretive guidance comes out, but we have to see those revisions related to plans for discharge are communicated to the patient, the representative, the caregiver, all the doctors issuing orders, and then whatever doctor is going to continue seeing that patient as a primary care physician after discharge. All that has to be communicated. At 484.60D, we see the standard for coordination of care, and we see that the agency must assure communication with all physicians involved in the plan of care. So again, we can't just communicate with that primary physician who's signing our orders. If we have physicians involved in the plan of care, whether they be pulmonologist, cardiologist, endocrinologist, whomever, we have to communicate with all those physicians involved in the plan of care, even if they didn't order the home health services. At 48460D3, under coordination of care, we see that the agency must integrate services, whether those services are provided directly or under arrangement, to assure the identification of patient needs and factors that could affect patient safety and treatment effectiveness, and the coordination of care is provided by all disciplines. What does that say basically? That regardless of whether the disciplines are your direct hires or contracted staff, that we have to make sure that they are identifying the patient's needs and factors that might affect their safety and treatment effectiveness, and coordinate care by all those disciplines. So again, we're talking about coordination of care, care continuity, that interdisciplinary team approach. All of that really has to be evident. In an interdisciplinary team, all the members work together, and each member contributes their knowledge and skills, and they interact with and build upon each other to enhance that patient's care. And I don't know about your experience, but with mine, coordination of care is an ongoing issue for most agencies. As a matter of fact, in the regulation and studies that I read, this tends to be one of the top 10 deficiencies cited by surveyors every single year when the survey results come out. So again, we really have to get creative with how we want our interdisciplinary team to work. Maybe you've got some experience in another setting. Maybe you worked hospice where they had a really good interdisciplinary team setting, and you want to mimic your agency's interdisciplinary team accordingly. Or perhaps, you've worked in a long-term care facility or a skilled nursing facility where periodically your team members got together and met and discussed what was going on with your patients. I know as an administrator and DON, several of the agencies we implemented that we had care coordination meetings approximately 10 to 14 days after this patient was admitted. We'd sit down and do a quick chart review and talk about what's going on with the patient, and then we would do that 30 days in and then 60 days in, or like your 60-day summary case conference meeting, and then you would do it as needed in between those times. But certainly you can really think about how your interdisciplinary team, who do you want on that? All disciplines need to be coordinating that care somehow, and it needs to be documented and demonstrated well. Now, CMS did leave this really open-ended so that you can assess how you want that to function in your agency and mandate and write your policies and procedures accordingly. But just know that you really have to show that care coordination in the new COPs. At 48460D4, you see that the agency must coordinate care delivery to meet the patient's needs, and you have to involve the patient, the representative if they have one, and caregivers as appropriate in the coordination of care activities. Remember, this is talking about your advanced beneficiary notices and so on as well, so that if you make a change in the plan of care or you no longer cover a service, that you're communicating that with the form, but also verbally and talking and explaining, and all that also needs to be well documented. Now we're thinking about coordination of services here as well. I just want to point out a couple things with you as well. For example, in the new conditions of participation guidance, that 60-day summary goes away. But in its place, we see that the discharge or transfer summary has to be sent to the facility and the physician within 2 days of that discharge or transfer. So the summary is not going away. It's just not a 60-day summary. You're going to have to do this summary at discharge or transfer and get it to that facility or physician within 2 days. The contents of your DC or transfer summary should be the initial reason for the referral to the agency, a brief description of that patient's home health agency care, a description of the patient's clinical, mental, psychosocial, cognitive, and functional status at the start of care, a list of all the services provided by the home health agency to the patient, the start and end dates of home health agency care, and then a description of the patient's clinical, mental, psychosocial, cognitive, and functional status at the end of care. And these were laid out in the proposed rule, and they were finalized in the final rule for the conditions of participation. You also have to add with your discharge and transfer summary the patient's most recent drug or medication profile, any recommendations for follow-up care, the patient's current individualized plan of care, and any additional documentation that will assist in post-discharge or transfer continuity of care that's requested by the receiving practitioner or facility. And remember, think again about best practices and coordination of care and how much more helpful that would be to the physician and or the facility from which you received this patient and where they're transferring. And certainly, don't be a hypocrite in so much as we expect our physicians and our facilities to give us lots of documentation, but we don't get them information in a timely manner either. So if you want to receive good information, you're going to have to be able to give that good information. And according to our updated conditions of participation, we have to make sure that all of this information is sent over within 2 days of transfer or discharge. At 48460D5, under coordination of care, it says that the agency must ensure that each patient and his or her caregivers, where applicable, receive ongoing education and training provided by the agency as appropriate regarding the care and services identified in the plan of care. The agency must provide training as necessary to ensure a timely discharge. And again, when you're thinking about this standard, think about the patient who needs training on insulin administration or other types of treatments. At 484.60E, we see the standard for written information to the patient. And this is kind of an expanded regulation that says the agency must provide the patient and caregiver with a copy of written instructions outlining the visit schedule, including frequency of visits by the agency personnel and personnel acting on behalf of the agency, patient's medication schedule instructions, including the medication name, the dosage, and the frequency. And here's a new part, which medications will be administered by the home health agency personnel and personnel acting on behalf of the agency. So in addition to your med profile that you have with your action, dose, frequency, and route, you'll now have to have a little column that says administered by patient or caregiver or administered by home health agency personnel. Your visit schedule includes the frequency of visits by the agency personnel and personnel acting on behalf of the agency. Keep in mind you're going to need to coordinate with that contract personnel in order to get that information in a timely manner out to the patient. And your contract staff will likely have to have their own system for informing that patient of visit schedule and frequency. So you're going to need to work out your policy and processes on that, educate your staff, and get all that ready before the COPs go into play, whether that be July or January. For the patient medication schedule instructions, including the medication name, dosage, and frequency, and which meds are administered by your personnel or personnel acting on behalf of the agency, remember that means all the medications, and this is not an exhaustive list here, but over-the-counter, prescription, topical, IV, IM, sublingual, by mouth, by peg tube, in the eye, in the ear. All of those medications have to be documented and the written information given to the patient. including the name, the dosage, and the frequency of each medication, and which medications are being given by your home health agency staff, and when are they going to give it. All that has to be written for the patient. You also see that you have to give them written information about any treatments that are going to be administered by the agency personnel and personnel acting on behalf of the agency, including therapy services. So, for example, you have a patient who has daily wound care, and on the first 3 visits, you train the caregiver, and then they have a return demonstration that they know how to do this wound care, and you're going to then do the wound care by the agency staff on Monday, Wednesday, and Friday, 3 times a week, and the caregiver is to perform it on the other 4 days of the week. You would need to have that written information to the patient talking about when the agency personnel is going to perform the wound care, and then when will the patient or the caregiver be responsible for the wound care. And all of that needs to be written and given to the patient and the caregiver. Then we see that any other pertinent instructions related to the patient's care and treatments that the agency will provide specific to the patient's care needs, and the name and contact information of the home health agency's clinical manager. And if you've been listening to the series, you know in the last webinar, we noted that the clinical manager is the person who really coordinates the care, and that's a new regulation under the updated COPs for this clinical manager. So you may have more than one. You need to know which one is for this particular patient, and you'll need to give the name and contact information of that home health agency's clinical manager in written form to the patient and the caregiver. E4 also talks about those discharge and transfer summaries, and remember that list about the initial reason for referral to the agents and a description of that patient's clinical, mental, psychosocial, cognitive, and so on at the beginning of care and also at the end of care. So we've learned a lot today about care coordination, assessment, care plan formation, and so on. So what should you do now? What's the next step? First of all, I'm going to want to assess those clinicians' assessment and care plan formation skill sets. I want to know what it is that they're not doing well and be working on getting that streamlined, certainly before the new COPs come into play. I'm also going to want to review and update policies on the coordination of care, especially with your contracted and part-time staff as needed. I'm going to want to create agency policies on the risk of emergency room and rehospitalization, educate our physicians and referral sources on the new COPs related to the plan of care. And of course, I'm going to want to speak to the software vendor about the changes they plan to make regarding the COPs in order to ease regulatory burden. Feel free to join us for the next 3 webinars in this 7-part series where we're going to continue training on the new and revised conditions of participation for home health. The next topics we have pertain to quality assessment and performance improvement, infection prevention and control, and emergency preparedness. And I really want you to think about, as we have a proposal to delay the COPs for an additional 6 months. And by the way, that has not yet been finalized. But as we know we've got extra time, don't sit on your laurels. Use that time to your advantage and really look at your policies and processes and procedures and get those finalized and start training your staff on any changes to your policies and processes, and really reach out to your referral sources and so on. Use that extra time to your advantage. If you have other questions, feel free to reach out to me at my email or my cellular number. My email is jgibson@axxess.com, and you see my cell phone listed here. The best way to reach me, as I travel quite often and may not be in the Axxess office, is to either use the email that you see here or to text or call and leave a message on my cell number, and I'll do my best to get back to you just as soon as possible. As always, I thank you for trusting Axxess with your training, and I hope you've enjoyed our webinar series on the conditions of participation, and certainly I thank you for what you do day to day to ensure that patients get the care that they need in the home, which is exactly where they want to be. Thank you again and have a wonderful day. Bye-bye.
Thank you for joining our on-demand training today and for choosing Axxess, a provider of innovative, cloud-based software, services, and solutions to help home health organizations improve patient care and grow their business. Axxess is the only healthcare technology company approved to award continuing education credits by the American Nurses Credentialing Center and is also the most recommended home health software on Software Advice. You can watch more on-demand training videos through our software or at axxess.com, where you can also find tutorials, blogs, white papers, and answers to frequently asked questions. Thanks again for choosing Axxess.